Thank you. Welcome everyone. Welcome to the third PXP conference, PXP 2025, a conference for and by patients. We're all about patient engagement in research. I'm proudly a member of the International Steering Committee that has designed and developed all aspects of this conference. If you'd like to find out more about the steering committee members, there's a link being shared in the chat. It is also available in the resource tab in the Zoom window for the first session of each day. My name is Joab Wako, and I am your host for the day. This is day one. I'm a person with lived experience. I've been living with chronic kidney disease for 10 years, which gratefully got a kidney from my sister Nerima 9 years ago. As a result, my work in advocacy centers around organ donation and transplantation. I'm connecting from Nairobi, Kenya, and I'd like to do a land acknowledgement. Nairobi was a swamp land which was originally inhabited by the Maasai, the Kamba, and the Kikuyu. It got its name from a watering hole known in Maasai as Ewaso Nairobi, which means cool waters. We acknowledge that we are being joined today by people from across the globe on land that has been stewarded by indigenous peoples for thousands of years. PXP is an international virtual conference, and some of our attendees may not be familiar with this practice. We encourage you to spend some time learning about and reflecting on what a land acknowledgement means. Please take time to share your own land acknowledgement in the chat if you'd like to do so. Here is a link below. A word about words, terms used. In some places, different words are used. Patient, patient partner, patient research partner, consumer, person with lived experience, patient and public member, patient engagement, consumer involvement, patient and public involvement. But know we're all here to globally talk about how people with different types of lived and living experience are working with researchers as partners in research. There will be a link below to go deeper into this. As you join today's session, you are asked to accept some community guidelines for PXP, and we ask that you all help to create an inclusive space with us today. For example, we'll have people who are newer to presenting, to hosting, or facilitating, and we want people to feel comfortable asking questions they wish to share and to share resources or learning. We kindly ask everyone to respect one another and be gentle as we grow our skills and knowledge together. New to PXP this year are booths. In the expo space of the platform, they include a booth with resources about patient engagement in research, booths for each of the 3 regional meetings PXP hosted this summer, PXP Africa, PXP Australia, and PXP India, and also a quiet room where you can go if you need a break from the session, which also includes mental health resources if you need them. There will also be rewatch parties each day, which will be opportunities for people to get together to watch a session together that happened earlier in the day. Rewatch parties will allow people to share thoughts in the chat together while watching these recorded sessions. So on to housekeeping and other information. Today, we'll have 3 one-hour sessions around the theme of what's happening and what's possible, and Ask Me Anything sessions to close out the day. There will be 15-minute breaks between the first 3 sessions. The first session, Global Voices, Local Impact, Patient Engagement Around the World. The second session, Roles in Research, Stories of What These Look Like and For. And the third session, Journeys of Impact, the Pathways of Patient Partners. And the final session is Ask Me Anything, about patient engagement in research in a changing world. Please use the Q&A function of Zoom to ask questions of the session speakers. we'll try to get as many questions answered as possible. Please use the chat function to share a bit about yourself, share any resources you'd like people to know about, etc. And we will be capturing all thoughts and resources shared in the Zoom chat in an anonymized summary for each session. Closed captioning is available to viewers through Zoom. Turn this on by selecting the CC button at the bottom of the screen as a viewer. You can then select the language you would prefer for these captions. We won't spend too much time introducing speakers. You can find the speaker biographies for each session in the resources tab and on our website. The link will be shared in the chat. Additionally, we would like to acknowledge all patient partners who move in and out of patient engagement in the research space, whether they are still with us or not. Our social media hashtag is PXP25. Feel free to share anything you wish on social media, and please know that we're recording the first 3 sessions each day, and they will be posted on the PXP website after the conference, so people who couldn't join now can watch later. While the conference has been designed for and by patient partners, of course, we welcome others who have joined us. Thanks to the conference supporter, the Canadian Institutes of Health Research's Institute of Musculoskeletal Health and Arthritis. There will be a link in the chat to the institutes. And now as I come to the end of that mouthful, I'd request that Hetty to put up the polls for this before we jump into the first session. Kindly fill in the polls and let us know what brings you to PXP 2025. With housekeeping out of the way, let me take off my hosting hat and put on my facilitation hat for session 1, Global Voices, Local Impact, Patient Engagement in Research Around the World. This session is to set the foundation for PXP 2025, and we'd like attendees to recognize that different areas of the world are at different places in terms of patient engagement in research. This session is to explore if there are similar challenges or opportunities that we can all learn from. So how this session is structured is we shall speak with patient partners in order of how long they've been in the research space. I'd like to invite the session speakers to introduce themselves briefly in 3 to 5 minutes or so. Note that their biographies, the full biography, can be found if you click the link in the chat that will be shared shortly. So to start us off, okay, I can see the poll. Before we start off, maybe I can just quickly look at the poll, and a lot of you are here to find new tools or approaches for projects, which is very, very interesting. Thank you so much for participating in the poll, our first poll of the day. So to start us off, I'd like to hand over to Nikhil. And Nikhil, the floor is yours. Kindly introduce yourself and start us off with this session.
Thank you, Joab. Hi, everyone. My name is Nikhil. I'm from India, and I live with a chronic condition of the intestine called inflammatory bowel disease. Those in the West might be familiar with it. I have Crohn's disease, which is one of the forms of inflammatory bowel disease. And it's been a decade since I was diagnosed with this condition, and over the course of time, I've gathered some more comorbidities. I live with an permanent ostomy as well, and last year I got diagnosed with thyroid cancer as well. My journey in patient research has been very, very new, and frankly, my experience is very limited. As a patient, I do feel like we should play a very we should play a big role in research. But what happens in India is patients are not really empowered to kind of get engaged in the research process. So the organization that I run, so I run an organization for people living with inflammatory bowel disease in India. And one of the goals of our organization has been to empower patients to, get engaged in research. But over the past few years, we have had a few conversations with, the researcher communities and the healthcare practitioners. And even though verbally, they have given, assurances or, some positive remarks about how they want to work with patients. But in reality, uh, like nothing concrete has happened. And usually, even the term patient inclusion is like a term, which is just put upon which is just put up for, just to kind of tick up a box, just to kind of, tick off a box, or, just to show to the community, maybe the international community and the national community, that we are patient inclusive. We think about patients. But to be honest, like it's more, like it's pretty hollow. So that's what I would actually say. And, we just had a conference last month, and uh, this time actually nobody attended the session, which was in which there were patient speakers. And we actually had to call some people to to even manage this, to even have the session. So that is how it has been. And yeah, I think that is why I connected with PXP a few years ago. And we really resonate with PXP's mission. And I'm also hoping to, learn some things about engaging patients in research, and hopefully we can, take all that back to our own country and do some things. Yeah. Thank you, Joe. Yeah.
Thank you so much, Nikhil. I resonate so much with your experience. For me, before PXP 2 years ago, I was involved in designing a research, and it was such uh, an eye-opening experience for me because I was able to bring the human element to the research and bring that background of our perspective, which was really valuable. But before that, the studies I had done, because I was on dialysis about 10 years ago, it was more like I was a participant. It's like they've already designed everything that coming to be for data, and then that's what my experience was as well. And the way you said they were like ticking a box. It's very tokenistic. And in fact, when we had PXP Africa, the same sentiments came through was how tokenistic research tends to be, especially in this region of ours, Africa. It's tokenistic, and that brings about a lot of mistrust between patients and researchers because once they're done with the research, they'll go with the data. Even one panelist said that they'll go with the research and you don't even know what the data said or the results of the data, which can lead to a lot of mistrust. Additionally, there's like the outcomes that come from the research. If the patients aren't involved, the impact that the research intended to have isn't realized because if there's mistrust within the communities, like when you come with the results in a paper or something, how will that be implemented if patients weren't partners who were just there for ticking a box, there to give our data, and that's it. So I really resonate a lot with you there. I feel there's just so much that needs to be done in terms of patient partners in our regions. I hope that we get more funding. I didn't realize how little amount goes to research in Africa, for example. And I really hope that patient-led organizations are empowered to to receive funding. And because I know that us as patient partners, we would ensure, because we've gone through, we know what it feels like to go through these things. So we would ensure that a lot of that funding leads to impact in our lives and people in the community's lives that we have here. We would ensure that that money does get there. So yeah, I believe we as people with lived experience would would really make that impact. And I would advise people who didn't make it to our region or areas of the country like PXP India or to PXP Africa to go and watch it because there was just so much insight in those webinars that we can't even put in 5 minutes here. So it would be really, really important to go and watch those. But moving on, I'd like to give the floor to Jeff or Ordway. I hope I said that right. So Jeff, the floor is
Yeah, you
yours.
got it, Joab. You got it. It was perfect.
Thank
I
you.
am coming to you from the center of the United States. I currently live in the middle of the state of Missouri. Um, I would like to acknowledge the Wasage people who first inhabited this land, and it's on their land that we trod while we live where I live. I'm going to give you a little bit of my medical background, just a very, very brief thing. My um findings, my issues, or I'm what is known as a chronic pain patient. Um, my journey started when I was in California. I lived in Los Angeles for a number of years, and I started having what I could only describe as cardiac arrest symptoms, and nobody could figure out why. And I went through about 3 to 5 years trying to find the answers to that question, talking to a number of different specialties, cardiologists, neurologists, etc. Nobody found anything. Every test they ever did came back clean. And in the United States, we have what's known as a primary care physician who basically directs all of your medical care. And my primary care physician started to believe that I was making it all up. And what happened was eventually I went to go see a chiropractor outside of the normal medical system, and that chiropractor found some problems and wrote up something that I then took to my primary care physician, and that convinced them to do one final test, which led to a full body MRI, which led to a 20-page report of findings that my vertebrae never formed correctly when I was a kid. That I have what's known as a degenerative disc condition, that the vertebrae, the discs in my neck had essentially disintegrated, and so there was pressure being placed on a nerve that mimics cardiac arrest symptoms. And there was a finding that came out research-wise at roughly the same time we were going through this, that a friend of mine at the University of California, Los Angeles, forwarded to me and said, "This might be your problem." And it turns out that exactly was my problem. So I've had a number of surgeries since then, in order to fuse portions of my spine so that I can actually function and do what it is that I need to do. I tell you this because this is why I do the work that I do. I don't want anybody else to ever have to go through the journey that I went through. And I'd love for us to be able to find answers faster and with less stress throughout the process. So I got involved in this work because when I moved to Missouri about 12 years ago, my new doctor said, "Hey, we're doing a pain study. Would you like to be a part of it as a person that we're studying?" And I said, "Sure." And as we talked, they said, "We want you to be actually on the study team, um, and guide us and teach us in everything that you can give to us." And so um, I got to be on a study team for our local university, and that led me to being on a patient advisory council for the local university, which led for me being a patient advisory council for a larger group, a group called the Greater Plains Collaborative, which is a data sharing group of 14 colleges and universities, mostly throughout the center of the United States. We also now have some spaces in California. Um, and that group has a tremendous amount of electronic healthcare record data that they generate, as you could imagine. There are, I don't know, I think it's 235 hospitals that are associated with these medical institutions. And so that gives us a lot of folks to be working with their data. I currently serve as a patient co-investigator for that network. And so I am at the leadership and governance for that regional network. Now, that regional network is part of a larger network that is known as PCORNet, the Patient Centered Outcomes Research Network. There are 8 of these clinical research networks inside PCORNet. And PCORNet's, I mean, it's large. There are 47 million daily interactions with doctors in the medical system that they have access to that data. Um, and I sit on the steering committee of that group. I sit in a leadership position in the overall coordinating center for that group. At one point, I was a senior project manager, which in a world of academics, here's a patient sitting in a world of academics as a senior project manager, helping guide engagement. for that group all the way through all of last year. So it's been a very interesting journey to go from being a guy with a back problem to being somebody who sits on this governing council level for such a large organization. So it's been a fun and interesting journey, but it's been a journey nonetheless.
Yeah, thank you, Jeff. I mean, it's so important for the system to respect the patient's voice, and that's something that I'm sure we'll delve deeper into as we finish up our introductions. Just seeing how your journey started and where it led to, it's amazing. Yeah, just so inspiring. Thank you so much for sharing. I'd like to quickly move on to Dominique. And before Dominique comes on, please note that we have a Q&A function. So if you have any questions, use the Q&A and I'll ask as we go along. Dominique, over to you.
Yeah, I started a bit earlier on my patient journey. I have asthma that has developed into severe asthma, and I got involved in the Dutch Lung Foundation around 2006. And at that time, not asked for by the Dutch Lung Foundation, a group of patients came together and said, there's all these research proposals going on, but how as patients can we have a sort of vision of how much are they for our benefit? So we developed a guideline where where we described what are the important questions for evaluating research proposals from a patient perspective. And that format is still being used in the Netherlands. It's quite easy. It's 5 questions. It's harder to answer, but it's quite, and we are still developing this. And from one of the advantages of being part of the Dutch Lung Foundation, because at that time, patient engagement was still very, very limited in the Netherlands. And but they organized a lot of training sessions to support us to becoming experienced experts, to learn how to talk about our experience with our disease a bit above just our personal level. And that helped me a lot. And from that experience, I became member of patient advisory boards of quite a few European research consortia. And from the first one, the rest followed. But this was each time a sort of, I was asked and I thought, okay, what am I going to tell you? But it sort of, they helped me develop and move further. And around 2011, so that's about 5 years later, the Dutch Patient Federation instituted a system where groups of patients looked at research proposals using the guideline we had developed before and giving advice to the clinical research organization that subsidizes the possible research. So I became one of these evaluators, and at that time, our advice was taken to the scientific advisory boards that would look at the applications, but not much was done with the patient advice. And I think since 5-6 years now, I am myself as a patient, am a member of 5 scientific advisory boards. And we're each time we need to prove that we have anything sensible to say. But once we've done that, our voice is accepted and listened to. And one of the major changes in my patient expert, whatever you want to call it, journey was the start of the EUPATI, the European Patients Academy on Therapeutic Innovation course in Europe. And for everybody else, you can contact EUPATI, you can talk to them, and you can have the possibility of taking the basics, which is how are medicines developed in all the stages and where can patients be involved, to take that information and adjust it to your own health system so you can make your own, in your country, Upati training. And that was really, really good, because that had an enormous impact on my involvement and feeling of security. I knew more. I became a better patient expert, and it helped me get involved in more areas of clinical and patient relevant developments. And that, by example, led that I became, in 2017, I was the first patient who became a co-chair in the European Respiratory Society Clinical Research Consortium. And from there, it just moves on and on and on. And I get that it's, at the moment, my biggest challenge is that because of my asthma is getting worse and worse and worse, how to manage my energy and sort of, I still enjoy being a patient expert every single day. I learn every single day, but my limitations often feel frustrating.
Yeah, yeah. It's so inspiring to see your journey, Dominique. And one thing that really stood out is capacity building and like knowledge, like creation and sharing. You know, there's a need for that as patient partners and as people with lived experience. So I know it can be frustrating, but you are making a very big difference. Know that. As we go into the next session, I'd like to invite Dominique and Jeff. It's called Hindsight 2020. But for Jeff, there's a question. So I'd like Jeff to address this question before you go into the Hindsight 2020, if that's okay, where we'd like you to share what you wish you knew about patient engagement in research when you started. But there's a question for you from Karen. And the question is, Jeff, for a guy with a back problem, you are now backing patient partners in governance roles. Grateful. What are your tips for others to help drive cultural and institutional change to have stronger governance with patients involved in the leadership team?
Wow, that's a that's a great question. I think my first answer to that is say yes when you're given the opportunity. And then every time an opportunity shows up, say yes. I will, full disclosure, my wife tells me that I have a problem and that I need to learn to say no more often. But because I say yes to opportunities when they arise, each one of the steps in my journey came because I was in a space and someone asked if I would be willing to move to another space where I was less comfortable, and it was a bigger space to inhabit. And so just saying yes to those things is important, recognizing opportunities and saying yes to them. And then I'm going to morph this also with my question or my answer to what would I do in hindsight is don't be afraid to speak up when you're in these situations, right? So the thing I wish I had known 12 years ago when I first started this journey was that don't be afraid to take up space in the room. Don't be afraid to ask questions. Don't be afraid to ask a lot of questions, because the reality is I'm probably not the only one in the room who doesn't know the answer to the question I'm asking. We assume that because we're a patient and we don't have the medical background or the research background, we automatically assume that everybody else knows what's going on and we don't. And the reality is that is not true. There's usually one person in the room who really knows what's going on. But everybody else has questions somewhere along the line. And man, I wish I had learned a long time ago that stepping up and asking those questions is probably one of the most important things we can do, because it not only lets everybody else learn stuff, but we ask questions in a way nobody else will ask them, because our lens is different than everybody else's. And so it allows people to answer a question so everybody can get the information, but answer that question in a way that is more directed, more common language, less technical, all those things. And my understanding of how this all works has gotten a lot better. You know, it's just been increased over time. So
I really like that, Jeff. Yeah, stand up and don't be afraid to take space. I really like that. Thank you for sharing. Dominique, I'll quickly hand over to you. What's your advice? Like looking back
Yeah,
from when you started.
yeah, I completely agree with Jeff. This is a very important lesson. I was in a scientific advisory board, and this was a new subsidy round, and we had all these applications. And when we started reading, we thought we have no clue what they were about. Only when we read the lay summary, we understood what the research was about. And the funny thing was, when I said this in our meeting, then almost all of the other members, or the clinicians and the HTA experts and the methodologists, said that they had exactly the same experience. So that's a good lesson that Jeff was telling us. I think from the hindsight, in Europe, it was a bit different. We started out in the 50s with patient organizations where they were basically about offering mutual self-help and exchanging experiences. And I think that's a big difference in people who start with patient engagement now. They're more directed towards research, and what's then missing is to have the group of patients around you with shared experience, where you can interact but also ask sort of, okay, what is the disease like for you? For us, the challenge was not only for us as the organization, but also for the Dutch landscape, is to move from this shared experience group to people who were more vocal and got more and more involved in research. And I think from especially in this type of patient organization, the 1980s and 1990s were incredibly important. That was when the breast cancer organization and the HIV organizations really went on the barricades, knocked on all the doors, were very, very vocal. And that lit a light in our minds as well, but also made a pathway and a learning way for us to know how to move from the small interaction space to bringing this experience to other people, and changing it from personal experience to shared experiences, then to how can this influence research, how can this influence the clinical space. So that was for us a very, very big change, but we had to fight. We had to fight quite hard to be heard. We were not, as my personal story is also a sort of history of patient engagement. And we were then invited to do something, but basically it wasn't listened to because we were just patients. It's each time I come into a new group, I feel like I need to show that as patients, we have sensible things to say. We have things to say that make a difference. We have things to say that will help research move forward. We will ask, and I always say in my own mind, there's no silly questions, but there's questions the others haven't thought about because they don't come from lived experience. They don't come from what's important for patients. They don't come from inside in, yes, all these nice clinical symptoms and outcome measures are interesting, but there's other things that are more important to patients to be researched and to be found out. So that's that's sort of my development. And I think what this has helped is on all areas. And if you start or if you're somewhere, there's so much information available. And go online, start searching. Like what Jeff said, I have the same principle as Jeff. They ask me something, and if it's possible, I say yes. And who knows where it will lead me? But everything is a learning opportunity, and by being well prepared, by looking at information that's there, looking at what's already been done, you come to a meeting really well prepared, and you tell them, yes, nice that you look at this, but research has shown that for patients, XYZ is more important. So how can we include this? And we can measure it this way. So there's all these, you don't have to invent the wheel yourself. It might not be exactly fitting for the Indian community or the African community, but it is a starting point.
Oh, thank you so much, Dominica. I think I'll summarize your sentiments as do the homework. Actually, do the homework and keep pushing to get your voice heard. I feel like there's a fighting spirit within the earlier patient partners that we, the ones who are entering the space now, need to embrace that. So thank you for sharing that. I've seen a question for Jeff, but I will ask you that question during this next session, Jeff. Please look in the chat and prepare for that answer. But I'd like to bring Nikhil back into the conversation, and I'd like Nikhil to share some of the struggles where you are now, and yeah, see what insights Jeff and Dominique have. So as they're preparing for that, Nikhil, please,
Yeah,
over to
thank
you.
you, Joab. Yeah, so listening to Jeff and Dominique, like I related to that a lot. So I think what we have been doing is definitely we have been, trying to connect with everyone, to be honest, like everyone we can find who has been working in this community. And that's how we were able to, host PXP India and everything. But one of the biggest challenges, like there are plenty of challenges, but like one of the challenges, like Dominic said, is like lack of energy. Like the problem is that there are not many people who are working in this area. And again, some of the people who are there they are not directly connected with the patient community. Okay, so there are not many patient organizations who have this as a focus of who have this as their focus. And like Dominic said, I think we are in the early stages where it's mostly like mutual support and sharing experiences and trying to help with health access. But again, I think so in our so we are a 5-year-old organization. I think we are doing decent in the space of like health access and everything, and we are now able to take some steps towards research. And one of the biggest challenges, as Jeff said, to not be afraid. But I think there's a big sense, and there's a big, reluctance to even speak up. And like there is also an element of like what I have experienced is that not many doctors want to listen to their own patients. Like they're happy, doing it at international conferences and, like engaging with people when they go to the West and see all these things happening. But when they come back to their own country, somehow this takes a backseat in their minds. And, they just engage in, like we talked before, like tokenism and just like, so that power dynamic. And then, just like, that the doctors are at the top of the pyramid and we can't really share a space where we are given equal in an equal opportunity to speak. That is one of the biggest problems. Even in research, like especially for our community, there has been no local research on what patients want. And the problem is doctors think that they know what patients want, but the reality is, we get so little time with doctors, especially in our condition. Like it's so complex that a lot of the patients have to go to tertiary care centers, and there aren't a lot of that. And there's a large volume of patients, and so all patients do not get a lot of time. So if I have 10 problems, I have to sort out like which are the two key things that I have to ask. And the rest 8 issues that, that might be actually, like hampering my quality of life. I don't get to that because, again, like it's like, but yeah, so doctors don't know that we have those 8 issues also because we are not telling them because there's no time for us to discuss with them. But they think they know. And that's how, like again, the lived experience gets, like uh kind of, thrown out of the window. And it's just like, what doctors assume that they know about how patients are living, whatever we are telling them in their, in the brief consultation. So this is one of the biggest problems that I'm facing is especially from the, like from the doctor side is how do we, make them take us seriously? Like, like how do we again assert our power or assert our voice and make them understand the importance of this? On the patient community side, also, like there are some patients who are interested in research. There are a lot of patients who don't know anything about health research. So we are taking some minor steps to educate patients about research so they can, they can better engage in this process. But definitely they want to share that there is a will or a want to tell more about their experience to doctors to talk about these things. But I think there is a lot of barrier from the, HCP and from the researcher community. There is a lack of, engagement. And even when we are given, like chances or opportunities, the inclusion is not there. It's really very, like it's actually, again, like I said, it's very hollow. And that is the biggest problem that we are facing. So if Jeff, Dominic, like if you have any, you know, have any advice on how do we actually make them, like listen to us, like that would be very helpful for us. Yeah.
Thank you. Thank you so much, Nikhil. Before you answer, Jeff, I just wanted to quickly add, I'm seeing time is going, so you just answer once. Um, I, I really resonate with what Nikhil has said and the time with experts on doctors. I guess we're all experts here, but with doctors. For me, I would just add like the trust. I feel that trust was a big theme that came up when we had PXP Africa, the trust between patients and researchers and doctors as well. How can we build that trust with different stakeholders in the space, not only, let's say, medical professionals, but with with just all the stakeholders? Because I feel like when you build that trust, it would you'd get to the point of where you're a partner because there's a respect that comes from that. So that would be my only addition to that. And I saw Jeff, I'm going to answer. There's a question for you about we don't always get compensated
Yeah,
for
I
our
see
time
it.
and
Yeah,
expertise. Perfect.
yeah,
Talk about that as
yeah.
well. Thank you, John.
I will. I will. So the first thing I want to say is about your point about trust, Joab, is one of my favorite quotes in our space in the United States is engagement moves at the speed of trust. Um, and so that if you have no trust, you'll never have engagement. But if you get it, then you can have engagement. And the only thing I can say to that, Nikhil, is trying to get doctors into the same mental space as patients. We do a lot of things where we invite physicians or researchers into a room, but we tell them, number one, we're not going to use honorifics. We only use first names. Number two, everybody needs to come in tennis shoes, no lab coats, no ties, right? Everybody is equal in the room. When you take away all the dressings, right, then it makes it a lot easier for them to listen because they don't really know who's who, right? You take away all those trappings, they don't know who's a patient and who's not when you start to open your mouth and express your opinion. So that's one thing I can offer to you that we have found works really, really well. Is to do that because it really kind of creates a different power sharing dynamic when everybody's literally on the same footing. It makes a difference. So really quickly, this question about people who, the question is, we don't get compensated for our time and expertise. This person says they're volunteering a lot, and but where's the line where it's too much? And that's a personal thing. One thing I will tell you is that all of the work that I do the CoreNet governance and the Greater Plains Collaborative is compensated. All of my time is compensated. And I'm now at a place where I understand there's some work that I do, like in development of projects and stuff like that. I don't get funded for the development, but I make sure that I'm written into the grant. Anything that I work to develop, my name is in the grant as a named individual, and I get paid for it. Because if I'm going to help you write this thing, you better pay me for it while it's going on, right? So but where is it that we're being taken advantage of? That's a personal thing. Like for things that I'm passionate about, I'll dump tons of time and energy into it unpaid, hoping that we will get something where I can be funded. So I just think that that's a really important, it's a great question, a really important question. And we need to make sure that that all of our work, once things are funded, that all of our work is compensated, every bit of it.
Oh, thank you. Thank you so much, Jeff.
Job, sorry to interrupt.
Yeah.
So just on Jeff, like, sorry to interrupt, but I just wanted to add to Jeff's point about like the compensation thing. The dressing thing is also like very good. I often feel the odd one out at medical conference, like seeing all the suits and all. It's like, yeah. But about the compensation, so like I just recently contributed to like a publication and I did a lot of the analysis part, but I was too scared to even ask that my name put on the list of like contributors. So that's this, like, I don't know if that's like a personal thing, maybe because again, I'm not from that, again, some of it could be my personal problem also. But I think that is a representation of how things are, really fair. Yeah.
And I understand that being afraid to ask. When I stepped into a new role at the CoreNet, I was used to being compensated at a certain level. And the person who was stepping out said, here's how much I'm making. This is what you should ask for. And that number was like way above anything I had ever earned in my entire life. And I was so scared to like ask the question. And the yes came so fast. I don't think they even heard me ask. They're like, yeah, okay, fine. So there's money available if we're interested enough and strong enough to ask for that money. That money for compensation for our time is definitely available.
Thank you, Jeff. Dominique, what are your insights here?
I was thinking about your first question, Nikhil. How the hell do we get at the same table? And I know the way we did it, but that's a long time ago, and this is still how it happens in rare diseases and in other disease areas, is to look at which clinicians are there that are interested in talking to patients, because it's this snowball. It is this small starting movement that then gains speed, and if one clinician says to another one, yes, but I talk to patients and in Crohn's or in pain or in whatever disease, this is what I hear from patients, and that is quite often the best way to break it open, is to look at, can we find clinicians that are interested in talking to us? But I know we had a focus group on intestinal disease, and there was a doctor that says, yeah, but I know everything about it. I don't have to be there. I know. And we invited her to the focus group, and she was sitting there, and at the end she said, I don't know any of this. Because as you say, they have 10 minutes of consultation, and what you can say is limited and what they listen to is limited. But this is a start small and it will grow. And one has talked to you or your fellow patients, and he says, oh, this is very interesting. We need to go and talk to them more. And yes, it takes time, but as Jeff said, don't be afraid. Don't, and of course we're all afraid and we all think we're silly and we all haven't got a clue half of the time, but we prepare. willing to put forward because we know it can have such an impact on not just our lives, but lives of so many people. And I always think if I'm wrong, but then I can learn something new. So I think it is that I would look at what other Crohn disease organizations have done worldwide and what's been, and I would then talk to a clinician and say, I've seen that there they do this. Would this be something we could do in India? Or is Crohn's very different here? This is the sort of open, it is especially important to start, and this is something I had to learn in the beginning, to start the conversation with open questions, with an open mind, because quite often we come already very frustrated with all our disease experience and not being listened to, and having been said for the umpteenth time, it's all between your ears and stuff like that. But this is what works.
Thanks, Dominic.
Thank
I think we are on
And
the right track. Like we
yeah,
have
but and it
definitely
is,
done some of
I
that.
completely agree with you.
Mhm.
It is such a big mountain, but it is a mountain that you take step by step. And suddenly you're halfway up and you think, how did I get here? Oh, because these doctors and clinicians are willing to help you, because for them,
Yeah,
quite often this is something they have been looking for.
yeah. Yeah, I think I felt like the same when we began our organization because there were some people I think who do not act because again there's nothing from the other side also because they also need patients and people from the patient community who want to be engaged in that process. But yeah, like you said, it's a very slow and painful thing, and I just hope I can keep up with all the illness, and I just hope I can like I think we need to bring in more people from the patient community as well as the healthcare community, so that it can become sustainable. I think that is one of the big issues, like how do I make this thing sustainable, especially with all the illness and everything that's going on.
Yeah, that's important, and I agree with you very often. And I think Jeff has the same experience in a way. You do a lot of this work on your own, but it's good to know that there is a community out there, and that there is the possibility to create communities and link up to other communities. And it's sort of look at which diseases have been successful in creating patient engagement in India, and see how, go to them and see how have you done this, what can I learn from you, because India is different from Europe. And so, and not, when we started, doctors were up there and we were hardly allowed to talk to them anyway. But we actually weren't allowed to talk to them outside of our patient doctor space, because that was forbidden by law. So, all these things can happen, and I think, don't forget that at this time, even if in your country is not yet usual, they do see that it is more and more usual in other countries, in other parts of the world, and it's even becoming obligatory. So you have the chance to move really, really fast.
Thank you. Thank you so much. I'm looking at time. We have 7 minutes exactly before the end of the session. There are some questions in the chat, and I would ask any of the panelists if you could go and type answers to those questions to save time as we move to the final section of this session, just to save time. But it's been really insightful. I feel like it's starting to get alive and we're running out of time. So let's go in the chat and please engage the questions there. And if you have anything to add in terms of opportunities and challenges you're facing in your region, and this is to the other patient partners, to everyone who's on this call, please add it in your chat. or in the Q&A. Would love to hear from you.
Joke,
So the final,
yeah.
yes.
Joke, there's one thing I want to add, which I think is important for the international community we address, is one of the things that I sort of knew but hadn't quite grasped yet. You need to remember that medical knowledge, disease symptoms, knowledge about the workings of medicines, side effects, and adverse events, minimally clinically relevant differences, all these things are based on research on middle to high class white males between 18 and 35. And not about women, not about other ethnicities, other age groups, and disadvantaged peoples and other cultures. So that's where you need to remain critical, because it's not at the basic knowledge on whatever disease can be the same, but it does not necessarily be applicable to your country, your ethnicities, your age. So remain very, very critical. And this is a question you're not allowed to ask. I once said when it was the first time that it became clear that women present completely different in heart disease symptoms than men. And I was at a cardiologist conference, and I said, yeah, but you're not 80% of your knowledge, if not 90, is based on white males between 80 and 35. I was not allowed to say that. And I said, but this is the reality, because these are the people that clinical trials were done on. So this is an extra layer of critical thinking I want everybody to be and remain aware. I don't have a solution, but it is an important aspect.
Yeah, it's very important. Is that your takeaway? I was actually going to ask everyone for their takeaways, or do you want another takeaway? Let me start with Nikhil, and then and then if you have any other 1 minute takeaway.
But because you went to questions, I thought it's really important that we all realize this.
Okay, thank you. That's very insightful, Dominique. Okay, Nikhil, I'm going to ask you what's your takeaway for the audience.
Yeah, I think so. I think I would first like to thank Jeff and Dominic for, sharing so much of their insights. And, I think what I'm getting is to kind of keep at it, like Jeff said, slowly. And, I think one takeaway that, again, for the people from India or from anywhere else where, like, I think, or any other community where patient, engagement is getting slow, is to maybe, again, like Dominic said, to, start those conversations and see, I think, who responds, and try to create like a snowball effect, as Dominic said. And also, to kind of keep speaking up and not be, afraid because somebody is, oftentimes we may not be allowed to speak, like Dominic, and that has been my experience as well. Once you start pointing out the real problem, there's often like, somehow they figure out a way to kind of, misdirect the conversation and all. And I think that signifies that you are really hitting, the target, and that is the thing they don't want to talk about, and that is the thing you have to talk about. So I think, yeah, keep talking about patient engagement, and, try to connect with more people who can, collaborate with you on this journey. And again, really, I think that the one thing that we are trying to do in our community is try to, encourage people to, again, assert their, voice, and, try to advocate for themselves. And again, really talk to their doctors as a, that I have the experience, and you need to listen to me, and, go from there. Yeah.
Yeah. I think my takeaway is just what Jeff said: engagement moves at the speed of trust. That was so profound. Thank you so much, Jeff. Thank you so much, Dominique. Jeff, what's your takeaway?
For me, I think Nikhil and Dominique summed it up incredibly well. I just would say one more time, just remember that the change is incremental and it goes slowly. In the United States, we have a phrase, slowly but surely, and I changed it to slowly but slowly, because there is no surely. We just keep moving. And Dominique said it so well. You just keep walking, and you look and you go, wow, look how far up the mountain I am, when I had no idea I was actually climbing a mountain. So I would just say, just keep at it and don't give up.
Great, thank you. I realized that there are some questions that we haven't answered, and I'll ask if we can maybe follow up with an email to answer the questions to the people asked, just in looking at the time. And since it's already time, I'm going to say we're going to take a break, a 15-minute break. Please come back for our second session, Roles in Research, stories of what these look like and offer. And yeah, thank you so much for joining, everyone.
Thank you.
Thank you, Joab. Yeah, this was nice.
Thank you for chairing the session, Job. You did really well.
Thank you. Thank you so much for all the knowledge, and thank you everyone for joining. I'm seeing there's been a lot of enlightenment, a lot of people ideas. I'm really excited. Look at the reaction. So nice. Thank you, everyone.